Hello, everyone. My case study focused on Ken, a 40-year-old male evaluated for elevated blood pressure. The subjective findings that influenced my assessment included Ken's cigarette smoking, frequent consumption of restaurant and carry-out foods, obesity, male sex, and family history of hypertension and coronary artery disease. Although he denied symptoms such as headaches, dizziness, chest pain, or shortness of breath, this did not exclude hypertension because the condition is often asymptomatic. Ken also reported loud snoring followed by gasping during sleep. This raised concern for obstructive sleep apnea as a possible secondary contributor to his elevated blood pressure. The important objective findings included a blood pressure of 146/94 at his wellness visit, a pharmacy reading of 144/90, and a follow-up reading of 148/94. His BMI was 31.6, His renal function, potassium, glucose, lipid panel, and EKG did not identify a secondary cause or evidence of acute target organ injury. Most importantly, his 7-day out-of-office blood pressure average remained 148/94. These findings supported primary hypertension and made white coat hypertension unlikely. Secondary hypertension remained part of the differential because of his symptoms suggesting obstructive sleep apnea. Masked hypertension and normotensive diagnosis were inconsistent with his elevated office readings. One area in which I felt confident was recognizing how repeated readings in different settings, combined with Ken's cardiovascular risk factors, supported primary hypertension. The 2025 Multi-Society Hypertension Guideline emphasizes accurate blood pressure measurement, out-of-office monitoring, cardiovascular risk assessment, and lifestyle interventions in patients with hypertension. One area in which I need further growth is distinguishing primary hypertension from secondary conditions that may cause or worsen it initially. I focus on confirming hypertension, but needed to consider the significance of Ken's snoring, gasping, and obesity more carefully. Shayna's 2024 review explains that obstructive sleep apnea frequently coexists with hypertension, and that intermittent hypoxia and sleep fragmentation can contribute to elevated blood pressure. My plan for clinical growth is to review current hypertension guidelines, use a systematic checklist for secondary causes, and incorporate a validated screening tool such as Stop Bang when sleep apnea is suspected. I will also practice interpreting office, home, and ambulatory blood pressure readings in at least 3 additional cases and request feedback from my instructor or preceptor. This will help me become more systematic and confident when evaluating patients with hypertension. Thank you.